Okay, thank you. Let's have Dr. Partha Biswas. We're going to talk about, I can't see the screen though. I don't know what is his topic. Okay, I think that's another area, faking also in difficult and challenging situations.
Good. Uh, Thank you very much, sir, for giving me this opportunity to be here today. Fake IOLs in difficult situations. I'll deal with ICLs. ICLs have stood the test of time, and I have been using ICLs for ever since, and I have no financial interests at all. But a lens that gives a track record of so many years, the material that gives a track record of so many years, I think it's a belief that and an honest belief that actually leads us all on. So, whenever there is a surgery, there definitely can be difficult situations, and to overcome such difficult situations is what we always do. Though difficulties in ICL is very minimal, just maybe in the learning curve, but it's very important for our youngsters who are going into the refractive surgery, the IOL-based refractive surgery, to understand that what happens when and what to do at that particular time. There can be these situations, very rare, but if one is addressed, one understands that this is a possibility and one knows what to do, then you can get over the trouble during the surgical process itself. So this is a video in which we have a stuck aptic, and this has got stuck. And why it gets stuck is something that I must dwell on while I'm stopping the video here. So this applicator is a very, very important aspect in the loading of the ICL, and the applicator is supplied by Star ICL. It is very important to use the applicator appropriately. If the applicator is not dampened, is not moistened with BSS, and one hastily places in the applicator and pushes the lens with the applicator into the nozzle, then it is a semi-hydrated applicator which will not work well. And this is one possibility that can happen. The applicator and the ICL can get stuck, and this is exactly what has happened. So here again, it is important, though the applicator, the ICL has great tensile strength. It will not tear easily, but it's important to nudge it out, to hydrate it, and at times that small wick to which the applicator is attached, that has to be tickled a little so that the ICL is nudged out. After that, of course, it's quite easy. It's placed inside, and then it's placed under the iris into the sulcus. So again, this is another situation. What is happening? I'll just dwell upon this point also. At times, the pupil might gradually shrink, and it might become a smallish pupil. It's important that if the ICL has been placed inside the anterior chamber, all that you need to do is to place in enough of methyl cellulose viscoelastic so that there's a pressure on the iris and it widens out. It's important not to nudge in too much or damage any part of the iris tissue, because the post-operative recovery might be quite stormy if such a thing happens. So nudging it in and placing the toricity in the correct axis is important, and that usually can be done. Now, this is what I was alluding to, and this is a patient in which the pupil was not dilating despite all our efforts for dilatation. And look what is happening. So here is actually, it was a trying time. Viscoelastic was placed a little too much in the anterior chamber in this patient, and there was a pop-up of the iris tissue. Now, when such a thing happens, it's very important to understand that we are dealing with only a small depth, just about 3.2 millimeters of depth of the anterior chamber. And if the iris comes up once, the tonicity of the iris tissue is lost, and it can come up again and again. So it's very important, again, to nudge it in very, very gently, depress upon the viscoelastic so that the viscoelastic comes out, and then placing and nudging the haptics under the pupil. Such things usually do not happen, but again, if it happens, it has to be tackled very, very gently so that as minimum of possibility of the iris damage is there. There is again another possibility in such cases that if there is an intraocular pressure that goes up in the first postoperative days, that may have two effects. One, of course, the patient can lose vision. The other aspect, of course, is the patient's intraocular pressure can come up and it can be very well controlled, but at times can give rise to a mid-dilated iris, a mid-dilated pupil, even for a very long time. And this stretch has occurred because of high intraocular pressure. The possibility of that tonicity coming back to its normal is very, very little. And there are rare instances in which patients have lived with a dilated pupil because of an early postoperative intraocular pressure rise. Now, this is one situation that every initial surgeon gets scared. What happens if the ICL goes upside down? Because we all know that there is a convexity, and that convexity has to be the right way up so that the ICL goes in the right way. So here we are, and this is one aspect that one has to be very careful about. The patient should not move while the injection is going on into the anterior chamber. So when it is going inside the anterior chamber, the ICL is going inside. This particular patient moved, and this is what we had. The ICL is half in the incision site, and we have to be very careful that it does not go the wrong side up. So viscoelastic, counter pressure with one of the side port instruments, and then usually it unfolds quite well. But once in a while, you have to give time and patience to see that it does not go upside down. Because if it goes upside down, it's not a catastrophe at all. This ICL can be taken back and again re-injected, but it is going to give you some amount of extra time for the surgery. So ICL exchange is something that we will dwell upon next. And it's not so difficult. It has to be done, again, the right way. And in this particular patient, the ICL had to be exchanged because of an inappropriate calculation of the power. So just look at this part where, the importance of the instrument is very important. Here, the grasp of the instrument is very important. And if the instrument is grasped well, then the first part is, of course, taking up one of the haptics into the anterior chamber. And once that is done, then with the cover of viscoelastic, one needs to grab the haptic optic junction. And it has to be done with this particular instrument so that the grab is good. And once the grab is good and once it is removed, at times it will slip. So here it has slipped, but then we are able to get a nudge of the one end of the haptic, and then hand over hand, atraumatically, and these are the Pierce-Hoskin forceps, it comes out in toto. Even at times, if the same lens has to be placed, it can be done. because there's no damage to the lens, and usually the lens can be placed back again. Of course, in this particular case, we have placed the right lens in, and it goes through the same incision. Don't need to change the size of the incision at all, and it goes nicely into place. So this is one aspect that all our learners should see. You don't have to go through such an experience at all. The YouTube videos are there for you, and once this is seen, and once you understand the importance of removing the ICL, then rest part is quite easy. So here again, the tucking in and orientation to the toric axis is important, and the right placement. And these patients have excellent results. It's not that because the lens has been replaced, the trauma to the iris or to the crystalline lens is minimal to it if everything is done properly and well. Now, this was an unfortunate case, and this is my last case that I'm going to talk about. So this patient had, do I have 2 minutes? Okay, so yes, so this is a patient in which we had an ICL, and we had checked for all peripheral lesions before placing in the ICL. The patient had to go in for certain services in which some amount of visual requirement was there, and got the job as well. But about 6 months later, he comes back with a retina detachment, and it's a detached retina. Our vitreoretina surgeon settled the detached retina, and again the vision came back approximately to 624 N12. After that, in about 3 months' time, this was the situation. So our veterinary colleague had said that there was a unfortunate lens touch, and this is what had happened. Now, with a situation like this, it's important to understand the importance of removing the ICL. Again, the removal of the ICL is the same way that we showed, and hand over hand technique, removing it as gently as possible, and it comes back in toto. But now it's a more difficult situation because the cataract has to be done in this patient as well. And with the cataract, as you can see, I'm gingerly trying to make a rhexis out of it, and it's a it's a cataract with a high intralenticular pressure, though using a lot of viscoelastic and cohesive viscoelastics. The situation goes out of control, and there is a run out. So, in fact, once the run out is there, I actually notice it's run out in 2 places. And these are very, very rare situations which might occur. And once a run out is there, then you have to be very, very judicious how to go ahead with the next part. Of course, removal of the cataract is not difficult, so we remove the cataract. But what we were expecting is there, and that plaque is there in the center where the lens touch was from the vitreoretina surgery. So we have to do something about that plaque, because once we place in the intraocular lens, the plaque will be there and will obscure the view. So what we do is we place in the intraocular lens, and then with an MVR blade, we go in and write puncture through the center of the plaque, and with the puncturing, and then we remove the amount of the posterior capsule, taking cognizance in the fact that we have to remove just the central portion, not beyond it, because if it goes beyond and to the clear portion, this posterior capsule might also tear and run out. So with a vitrector, very, very gently to make a small circle of space in the plaque of the center of the posterior capsule. So once this is done, the lens goes into place. The patient did recover very good vision, which was as much as we could offer the patient, about 660 vision. And this is how difficulties can be surmounted, but difficulties will occur, and such things are not a deterrent to our practices of the ICL. And I leave you with a message that all these are rare situations, very rare situations. But if you know what to do in even a rare situation, one definitely gets on to, you have to be on board of phakic intraocular lens. Thank you very much.
Thank you, Dr. Partha. Any comments from any of the other experts? Or any questions? Okay, thank you. That was a very nicely illustrated overview of the challenging situations and good tips as to how to handle, because that is extremely important to preempt and take care of it. There was a suggestion that for ICL explantation, as you had shown the traditional method of holding from the foot plate of the haptic and then hand over hand technique. There's also been another suggestion in the previous by speaker that if it is upside down, then you could hold it from the center because the haptic is already a little bit elevated. But I think the foot plates are a little bit more free, and getting the foot plate out and then pulling it by hand over hand. So I think maybe yes, please.
Ma'am, may I just add one thing to that? Uh, One small trick while removing that first haptic out is that the other side of the haptic should still be the sulcus, and not taking the whole optic haptic out, means all the four haptics should not be out. Then what happens is the ICL is sitting tight on the iris plane, and then you cannot maneuver or catch one of the haptics to remove it. So if it is at an angle, then that angle is pointing more towards your incision site, and it's much easier to grasp it and remove it. So that's one thing that
Yeah. What is important is always to see your patient very carefully before the surgery, see on the slit lamp, imagine where is the structures, etc., and then plan your surgery and then proceed in a very systematic fashion.